monitoring the message and plan to make this a very interactive session, soliciting your input throughout different ways. Please also engage online by using hashtag #YesHealthEquity. Yes to health equity. We'll be live tweeting points during this event. Let's make it dynamic. You'll see our Twitter handles and hashtags again. Once again, just look in the chat. Please share yours as well. Now, I would like to introduce Dr. Matthew Kavanagh, an old friend who works at the intersection of global health, politics, and law at Georgetown University. A political scientist by training with a long history of work in global health policy and politics, and his research and writing focus on the political economy of health policy in low and middle income countries. And it's really awesome to have Matt today with me. And we will have some thought-provoking conversation today. He's assistant professor of global health, visiting professor of law, and directs the Global Health Policy and Politics Initiative at O'Neill Institute for National and Global Health Law. Matt, I hope you recall, we traveled in circa 2007 to many campuses in the US to build the advocacy for health equity. More than 15 years ago. I can't just, it just seems like I'm, and it wasn't, health equity wasn't even mainstream at that time, Now it's like, we'll talk about it. Is it becoming a buzzword? Over to you, Matt, to share some thoughts, your thoughts on health equity, what health equity is.
No, great. Thanks, Vineeta, and thanks to all of the organizers. I'm really thrilled to be here, and especially excited to be here after a long time where we have not gotten a chance to work together. And so hooray for that. So as Vineeta said, I run something called the Global Health Policy and Politics Initiative at Georgetown University, where I teach and I'm on the faculty. But I also have a long history of work in global health equity as an activist, as a thought thinker, as a writer. I used to run a number of pieces, including worked for Action for a short period of time. And so, really glad to be with you all today, and excited for all of the interesting prods that Vineeta has come up with to get us to kind of think interestingly and a bit provocatively. So Vineeta asked me to just kind of kick off with a kind of broad question around how do we think about and define health equity to kind of give us a start. So the World Health Organization defines health equity, and I'm going to read it here, which I never do, right, as they are the differences in health status or in the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. Health inequities are unfair and could be reduced by the right mix of government policies. So this is the core, this is the WHO definition of health equity, right? And so I think as many of us think about this, we often, those of us who work in global health or in public health or spend time advocating around those things, we usually talk in totals, right? If we were together in a room, I would make you raise your hand of like, how many people have been in to lobby or do some sort of advocacy, and they cited some number like the total number of people cured of TB, the total number of people dying of TB, a country's cure rate, right? The percent of children immunized, the number of child deaths, right? And these are kind of the stats that make up the DNA, I feel like, of global health and of especially global health advocacy. And yet we almost always talk about those in absolute terms. And what an inequalities lens does is it brings and it says, look, we need to think a little bit deeper, because often when we talk in generalities, it masks inequalities. And those inequalities are not only unjust, which they are, they're also bad for public health. Because one of the things that is increasingly clear is that health inequalities actually make everybody less healthy and actually drive overall poor health, right? And so, for example, when we shift to an inequalities lens, what we're doing essentially is we're comparing, right? We're saying, what are the differences between folks, right? So for example, Black South Africans live 16 years less than white South Africans, right? Then, the overall mortality rate or the overall age of, age of death and years lived is vastly different by racial categories. I live in Washington, D.C., right? If you live in, and I'm just looking here, if you live in Montgomery County, you live 84 years is your average. So Montgomery County is a relatively white, relatively wealthy suburb of Washington, D.C., where the life expectancy is 84 years. If you then cross the border over into the District of Columbia, your average is 78 years. If you then go into Ward 8, which is where the most poverty in the district is located, it's also a primarily African-American district, there you're falling into the low 70s, 72. And so you've got, even within the same city, right? It takes you literally to drive from Anacostia in DC to drive up to Montgomery County. It would take you probably about 15 minutes. In that move, you might get, you gain 15 years of life or 10 years of life. That's what we're talking about when we're talking about the kind of health inequities, that kind of a lens, right? And so we might also think about kind of, a few other examples, right? So, in many countries, right, impoverished women are far less likely to be attended by a skilled birth attendant. So when we talk about child health or we talk about maternal health, that's deeply wrought by economic power, right? So the poorest 20% in many countries, right, have between one and 2 out of 10 women or have their births attended by a skilled birth attendant, whereas in the wealthiest 20%, 9 out of 10 do in many countries in the global south, right? Members of the Inuit tribe in Canada, they're 300 times more likely to have tuberculosis than non-Indigenous Canadians. And so these are the kinds of things that we're talking about when we're talking about inequities. We're also then talking about kind of 2 different kinds of inequities. We often talk about absolute inequities and relative inequities. And so what I mean there is, right, we can talk about absolute inequities, meaning, look, there's a 12-year different gap between the richest and the poorest life expectancy, an absolute difference. But often what's even more interesting is to look deeply and understand, how is that relative to each other? So look, if there is, for example, let's imagine a theoretical community. And in that theoretical community, there's a 20-year gap between the richest and the poorest in terms of their life expectancy. That is in and of itself deeply problematic. But what if life expectancy is 40? That means you've got some people who are living half as long as other people. But what if the life expectancy in the community is 90? Then you've got some people living to 90 and some people living to 70. And so the absolute difference is exactly the same, but the relative difference is actually significantly different, right? And so this is the kind of conversation that we want to have when we're looking at a health inequities lens. Why does it matter, right? And the biggest thing that we want to think about, from the work that I do and my perspective, is that what inequities do is they not only are unjust in and of themselves, but they are what we call a social bad, right? And so it leads to a broad set of problems writ large. So one of the things it leads to is ignoring, right? So if we, especially when we're talking about infectious diseases, which is most of what I work on, right? So if we're talking about infectious diseases, if you have got these deep, deep inequities, then what it absolutely leads to is you've got the majority are doing pretty well, right? People who are well off, who are sealed off, who are able to live their lives in certain ways, and think COVID right now, right? Those of us that were able to be at home, be living virtual lives, we still got our paychecks every day. That reality is then cleaved off from the folks who are experiencing high rates of transmission. And when you get that kind of inequality, what you get is you get ignoring, right? And so, for example, one of the, much of my work is on HIV. And so the core paradigm in the last few years on HIV has been that we want to achieve something that we refer to as 90-90-90, right? Which is 90% of people living with HIV know that they're living with HIV. 90% of those who know that they're living with HIV are on treatment. And then 90% of those who are on treatment are on really good treatment, and therefore they achieve viral suppression, right? And what we know in HIV is that if you can achieve viral suppression, you not only don't die, but you've got 0 chance of transmitting HIV. And so it drives down inequalities. So what we see is great. This is a really nice, it drives down new infections rather. So what we've got is, okay, brilliant, a really nice, exciting new paradigm, hooray. And what we see is that some countries achieved 90-90-90 and radical declines in new infections and deaths happened. Some countries got near 90-90-90 and almost nothing happened. They saw no change. And they said, what in God's name is happening? Well, what's happening is, in some countries, the 90-90-90 is equitable across all populations. Most people achieved roughly the same amount. And so when you said a national 90-90-90 paradigm, great, we saw new infections. In other countries, you know what we got? We got 100% of the, and this is genuinely true, nearly 100% of the older women were on treatment who were living with HIV. They knew their status, they were on treatment, et cetera. But frankly, those older women were not the ones who were having lots of sex. They were not the ones who were injecting drugs. They were not the ones who were experiencing HIV transmission. The young people had really low rates. And so you saw this, especially key populations, especially folks like gay men, right? Had very low, young gay men especially had very low rates. And so what you end up with is, it looks the same. They both tried to achieve 90-90-90, but the people who were left out in the one example where there was deep inequality, those were the people who were experiencing HIV transmission. Those were the people who were dying. So the actual impact of the intervention was almost nothing. One more quick example, right? Singapore, COVID-19. Singapore was doing brilliantly addressing COVID-19. They had very low rates. And then all of a sudden, there started to be a little spike. And they said, don't worry, that's just a handful of cases. It's very, very small. And then there started to be a little bit bigger spike. And they said, don't worry, it's just a handful of cases. It's very small. And then all of a sudden, there was an explosion in Singapore. What happened? The migrant population in Singapore was uncounted. It was not paid attention to. And what you ended up with is they were hiding from the authorities because they were not all, kind of papered and legal in the country. And therefore, those folks were experiencing a whole ton of COVID-19 transmission. And so that resulted in a big outbreak in Singapore for a minute that spilled over into the whole population. But the whole point was that they were saying, oh, there's just a few cases. But nobody was paying attention to those just a few cases were among the most marginalized who had the least access to healthcare. And that ended up driving an epidemic for everybody. So I'll kind of stop there and talk about we can talk about where the drivers are and how we think about some of the structures of health inequality. But I'll just close by saying we then often think in kind of three different layers. We say, look, what are the health outcomes that are inequitable? What are the health services and risks that surround those health outcomes that are driving those health outcomes? Not everybody has the same risk. Not everybody has the same health services. And then around that, how do we think about the laws, the social, and the global? And so we'll talk about that as we go. But maybe I'll stop there, Vineeta, if that's good, and go from there.
Thank you, Matt, for setting our brains to this length and breadth. Appreciate it. Like you mentioned, disparities within countries and between countries. In the US, if you see the only country where the maternal mortality rate, death rate has gone up, and it's a Black maternal mortality rate that has gone up. I mean, it's just the country is rich, it's a superpower, gives money to everybody. And still we have our own disparities that affect social, cultural, economic determinants of health. So let me start by posing a question to you all. Is health equity becoming a buzzword? You will see a poll on your screen. If you think it's becoming a buzzword, then please check yes. And if you think it's not, then please check no. I'll give you a few seconds for you guys to do the poll. Is health equity becoming a buzzword? And we'll talk about why it matters. Matt, it's kind of a surprising how many decades later, I can almost pull the PowerPoint and the presentations that we did 15 years ago and just similar issues. I mean, more complicated, actually, it has become more complicated with, newer forces jumping in,
It's really interesting, right? I mean, I feel like one of the core one of the core things that's really interesting for us to kind of think through is especially the kind of between country and then within country, right? I think we're often used to thinking about the differences between country without noticing that actually the within country inequalities are often as big or bigger, right? And when we ignore those, we kind of end up with a class across the entire world who actually has worse health outcomes in deep ways. And so, but I do think that, many of those same drivers are there. Yeah.
Correct. So we have the polls in. 70% of you think yes, it's becoming a buzzword, and 30% of you think it's not. So I'm going to ask a volunteer from the yes group, and then I'll ask a volunteer from the no group. Can you please unmute yourself or raise your hand, and I can call upon you, or Sabina or Maddie, you can help me identify one volunteer to talk about why do they think health equity is becoming a buzzword, very briefly. Any volunteer?
I'll go.
Okay, go ahead.
This is James Lee. I'm in Charlotte, North Carolina. We tend to use buzzwords as like a launch to do something, but it's not really doing anything. You know what I'm saying? It looks good on the outside, but it's not really doing anything internally to health. You know what I'm saying? The health equity is still not going to be right because they're not going to do it right. You know what I'm saying? It's not going to really reach down to the people that it wants to reach to. So yeah, I think they use it as a buzzword.
Thank you, James. Thank you. And can we get one volunteer to briefly share why they think it's not a buzzword, it's not becoming a buzzword? Any volunteers?
Just because you did not win the poll does not mean it's not a really important thing to share. Yeah.
I see Bruce Davison has his hand up.
Yeah, please go ahead.
Yeah, what I find in my work and results, although I'm very much involved in results, we do talk about it. But in most of my everyday life, work and going to stores, people are unaware of it, in my opinion. They do not talk about the general population. In my little universe and results, yes, it is. But I say results is just a very small portion of the population. So it's just in the communities that I live outside of Buffalo, New York. So in the communities I get involved in church and school and work, people do not talk about it.
Thank you, Bruce. Thank you very much for sharing. It's exactly right that it's a buzzword in the communities that are working on the health advocacy or funding health sector or connected in one way or the other. Who make the decisions, right? They are part of the major forces who drive the decision on health and health equity. So I have been in this field for over 30 years, and I think that we are hearing health equity more and more from both aspects, from people who are advocating more and people or entities that are sounding it as an empty word. And I worry about it. I worry about it, as they say, when the agenda of the people gets hijacked by the entities that reinforce that agenda, then it gets diluted. Then the actual work gets diluted. Matt, I want to hear your thoughts on what do you think? Is it becoming a buzzword? It's not. If it is yes, then what's the flip side of it?
Yeah, no, I appreciate both James and Bruce, your interventions here, because I think you're both right. I wish that what I was hearing in mainstream conversation was mostly about health equity, right? And it's really not, right? I mean, what do we hear most of the time is very much on occasion you hear about equity, but most of the time, if you hear anything about health, it's first of all, it's U.S. health, right? It's purely kind of domestic. Occasionally you hear something about kind of international health, and it's relatively rare. But in both the conversations on U.S. health and global health, I think it is rarely about inequity. But then to your point, Vineeta, I think within the world, and Bruce, your point about like, what we use it a bunch in results, but not elsewhere. Like, I think that's right? There's a world of folks who have started shifting to thinking about inequity and thinking about it. But there, I do really worry it becomes a buzzword, right? I really worry. And so, one of the things that I think is a core question is, if you notice something, if you notice the inequity, if what we do is we draw out all of the information about it, but we don't actually act on it, is that better? And I think to me, that's kind of the definition of a buzzword, right? There have been tons of studies that have been out recently that show and document and describe and give brilliant, brilliant pictures, right? So I'll just share. I didn't do a presentation or anything, but I'm going to share. Am I allowed to share my screen? I think so.
Yes.
Okay. Here we go. Yeah. So like, here's one example, right? Of like, here's a good image of of some work that's been done that shows the District of Columbia, right? So we've got these kind of, really nice looking kind of images that illustrate the kinds of inequalities. Here's Philadelphia in life expectancy, right? If you're, downtown, you've got 88 years. If you're over in the corner, you've got 73 years. And so you've got these kind of things, right? We can do the same with New York City, right? Oh, sorry, this is the District of Columbia again. There was a New York City one. I don't have a Buffalo one. I was hoping that maybe we did, but you guys get the point, right? That there's kind of a lot of work that had never been done before until recently, right? That really did think deeply about, okay, what if we looked zip code level, right? And we were actually able to show the differences in health outcomes. So that work is increasingly being done in pretty sophisticated ways. As I said at the beginning, a lot of my work is in HIV. And one of the things that we used to talk only about was we would talk about broad strokes, the HIV deaths and the HIV new infections in a country. And in recent years, there's been a thing called the public health impact assessment, public health HIV impact assessment, the FIAs, and it's actually been funded by the U.S. government, right? It's funded by PEPFAR and USAID, and what they've been doing is they've spent a bunch of money, I think very well, in going in and documenting in high burden countries with HIV what are the differences between populations. So they've been looking at the differences between men and women, right? And discovered that actually it turns out that fewer men are on HIV treatment than women, right? Which is interesting. So we can kind of have that shown that actually young people are far less likely to be virally suppressed than others, but also shown huge disparities in geography, right? Shown that what you see is hotspots where there's kind of high HIV transmission rates and then places with very low HIV transmission rates. And so starting to think about those, and those are tied to wealth and race and power. And so starting to think about those, we've been documenting them. And I think this is actually very good progress. It's very important. But I think there is a bigger moral question, which is it better to document the impact and then not actually take any action on it? Because I feel like that's where we are. Right? Where we are documenting it, we're talking about it, we're noticing those inequalities. But I don't know, philosophically, is it actually better if you document them, you research them, you know about them, and then you don't act on them, than if you don't document them and don't act on them? I'm not sure which of those is better, but I don't think we're in the kind of, maybe that's the definition of a buzzword. Anyway, yeah.
Yeah, no, very good point, because I think that when we do that, there's some validation that we are working on health equity, but it's not reaching where it needs to reach, right? And it's, let's talk a little bit about vaccine equity. It's on everybody's mind. COVID-19 if it has done anything, it has exposed the already existing disparities that existed. And you should see another poll on your screen. Please, check yes or no if you have received COVID-19 vaccination. It's the results are anonymous. Nobody's going to see who checked what. It will just give us a general sense for who has it in this group and who does not. And we'll talk about why it is important, the percentage. So we'll wait for that a little bit on there. While we are waiting, Matt, any words of wisdom on the vaccination, COVID vaccination? Oh, we got the polls. Sorry, Matt.
Oh, great. Go for it.
Yeah. So the polls are 96% of the audience has a vaccine for COVID. What a staggering number. Thank you that we are able to get that, the vaccine for COVID. Now let's look at the rates around the world, right? Globally, it's only 12%. 12% of the people have been able to get the vaccine, and I bet most of them are from high income country groups. US is at 52%, Canada is at 64%, India is 14%, Bangladesh 3%, Benin less than 0.2% of access to vaccination and gotten vaccination. I, as a volunteer, worked with Indian diaspora who kind of came loosely together to respond to the situation in India. You know, we have our deep connections, no matter where we live, the people, the family, the country that we come from. And it was just mind-blowing, heartbreaking, and frustrating to see how first the COVID hit and what people were going through. For a lot of reasons. And when the vaccine started to become available, it was very difficult to get the vaccine. It was more available to the richer people who could pay. And then the poor people, and the vaccination was, appointments were made, they were canceled. So the point I'm trying to make is that within countries it exists, and between countries health equity exists. Vaccine equity is not just a piece of the bigger puzzle of health equity. We cannot go vertical on solving the inequities within the health field. So let's just hear a little bit from you, Matt, about a situation. What do you think, reflecting on the poll, and then we'll move on to the next.
Yeah, no, I mean, you know, it is, first of all, it's great to see that everybody, that so many people have been vaccinated. So that is great news, right? I mean, the science of COVID-19 has been remarkable, right? I mean, you know, it's worth noting, right, that obviously many of these vaccines have been, you know, a decade or more in the making. There's some brilliant work going on right now by a whole bunch of scientists who, you know, are kind of having these breakthroughs so fast. And why did that happen? Well, it happened because there were, you know, billions of dollars rapidly put into discovering and developing and moving out a vaccine into the world, right? You know, if we look at just one of the vaccines, so right, I was able to get the Moderna vaccine. The U.S. government paid $2.7 billion within months to try to bring that one to fruition, and then buy it and spend it around the world, right? And so billions of dollars have been invested in these vaccines, but the inequality and inequity in terms of access is just striking, right? So last I saw, 0.4% of all vaccines have gone into arms in low-income countries, 0.4%. And so, you know, we can think about it that way. We can also think about it in terms of kind of, you know, what's the ethical implications of how they're being allocated, right? And so if we look in the United States, we are now moving into vaccinating healthy young people so that they won't get COVID-19, which is good, right? I want young people to get vaccinated. I want them to have access. But meanwhile, if you look in African countries, most African countries only have enough vaccine to cover a quarter of their health workers. And so that is striking, right? If you've got on the one hand healthy folks who are able to stay home in the United States and, you know, and do their work, and on the other hand, you've got health workers who are on the front lines of COVID outbreaks, and only a quarter of them are actually vaccinated, we're in a crisis, right? And this is the most acute crisis, at least in my lifetime, that I can picture when it comes to the levels and speed of inequity, right? In HIV, it took us a decade to get to anything close to high coverage of HIV treatment. We're now within 6 months, within high coverage of vaccines here in the United States, and yet deeply, deeply inequitable elsewhere. And so I think the core question of kind of why and what's driving that is maybe where we go next.
Yeah, and Matt, I'm going to put you on spot again. On the next question that we have is, who and what we think is perpetuating health inequities? Like, is it what kind of entities, what kind of people, and then we'll move on to briefly discussing, first we'll briefly discuss who and what is creating or reinforcing the perpetuities, causing health inequities. And then we'll have a whiteboard discussion among the audience, what can we do about it? So if you can briefly touch on what and who of health inequities.
So we think, or I think, kind of writ large, and one of the things that one of the hats that I wear is that I actually chair the UNAIDS advisory board to the executive director, and UNAIDS just passed a big new global AIDS strategy. And I last week was up in New York and actually went to New York and was in person for a handful of meetings, which was crazy. That we're moving into in-person life in a little bit, right? So I went to some meetings at the UN because there was a high-level meeting on HIV that was happening, and so member states were all gathered to talk about it. And the new global AIDS strategy really does focus on inequities and inequalities, right? Because of those kind of reasons that I showed, right? The last 5 years strategy focused not at all on inequities, and we failed to meet the global targets that we were trying to go toward, right? You can think about the same thing in TB, you can see the same thing in maternal mortality and child health, all of these pieces. We are not achieving the goals that we're setting out to. We are nowhere near on track to actually reach the SDGs if we are honest about how we count them, right? And so to me, the core question is kind of what are those intersecting rings? So I said at the beginning, kind of one of the core pieces for me is to think about outcomes at the center, right? Those inequalities are what we've got. But then to think about the services and the risks. Who have the services been built for, right? And so, for example, one of my colleagues kind of said this thing where she said, like, look, I order my medicines at CVS and they deliver them to my house. That's pretty convenient, right? But 2 months ago, I was in Haiti, right? Where folks lining up for TB treatment were going and spending their entire day waiting in line at a clinic to get access to the services, right? And so the difference of being able to sit in your house and have your drugs delivered to you or spend your entire day, trying to do that, and my colleague was like, look, they're going to pay me wherever I am. I can sit in the waiting room if they want, and I can be on my laptop because I'm a virtual worker, right? But meanwhile, this other person is literally sacrificing their entire day's worth of work, where they are a seller in an informal setting and they're not getting access. So there's really differences in services and those kinds of things. We also can think about the differences in risk. Right? So, again, COVID-19 makes such a good example of this, right? Of like, how do we think about the risks that each of us live with? And I think it's been hard before COVID to talk about some of these in the ways that we can, but right, I'm a professor. I have been teaching online. The risk of COVID-19 from my screen is zero. Right? But the risk of folks who are doing food service, who are doing kind of frontline pieces, the risk to my brother who works in an ambulance, right? Like those risks are really different. And so different people face such different risks. But then we often stop there, right? And to me, the core question we need to do is to wrap around that what's actually going on. So how do we think about the laws and the policies that actually drive that, right? So if we think about kind of risks, one of the things that we work on a lot is the criminalization of certain people, right? So where gay relationships are criminalized, people go underground, right? And so the law itself drives people away from HIV testing. There was a paper that we wrote a couple of years ago that looked at TB the same way, right? And we looked at TB, and it turns out that actually there's all these laws related to TB about reporting. That if you don't report on your, pieces that actually impose jail time on people for non-compliance with TB pieces. And again, back to my colleague who was like, look, I go and I if it is raining outside, I don't walk up the hill to my CVS. But if it was raining outside and I might be arrested, I sure as heck am not going to walk up to the CVS. And so laws also structure these kind of questions of access, right? And then finally, I would say that you've also got these global, pieces, right? Where at the global sphere, which countries are able to deliver for their people is really structured by global, by global structures and global norms, right? So things like which countries have the funding to be able to provide high quality health services is deeply influenced by the IMF and the World Bank and the policies that they make that impose huge limitations on, for example, the ability of certain countries to hire nurses. What have we done in the United States in the middle of this pandemic? We have invested billions, in fact, I believe trillions of dollars now, right, in trying to pump into the economy to have a response, hire the nurses, hire more health workers, do all of that stuff. Meanwhile, on the other hand, countries that are in economic distress are being told by the IMF, you need to cut your budgets in the middle of a pandemic. So we also need to think about these kind of big structural questions. And then finally, I'll just end by saying, I also think we need to think about kind of who's in charge of some of these things, right? And so we are, for example, right now in the middle of COVID, right? We've got COVAX, and COVAX is brilliant, but it's set out to only get 20% of people in low and middle income countries access to vaccines. The African Union folks have actually been saying, wow, why didn't you consult us in the strategy here, right? Why didn't you do that? And so thinking about kind of to what degree are decisions made in Washington or made in Geneva or made in other places that affect the lives of people. And one of the core principles of an inequalities lens is that we pay not only attention to who, who's having differential health outcomes, but also who gets to make the decisions. And if the people making the decisions are not in any way democratically accountable to the people receiving the services, then we get deeper and deeper divides in whether those services work for people. And I think that's where we're at right now is increasingly, right? We need to be pushing for not just the funding, but also the funding and the power to be shifted to the people who actually are the communities that are affected by it, rather than just assuming that folks in DC or Geneva know better.
Thank you, Matt. And it's just, there comes the partnerships, where there are global partnerships who they're equitable, and then decision making is not on the dollar amount or the where you live or how you look. The partnership is more based on mutual learning and a discourse that's without fear. Like I have been Matt was talking about the policy issues. How many policies that are made in US that impacts a small, tiny village in India or in some country in Africa? It's phenomenal how deeply that affects. I mean, we'll talk about the recent, in the recent past, the policies on reproductive health, right? How did it affect the women in the poorest and the remotest areas of the different countries, because the money was, money dried up for those reproductive services because of the US policies that happened. And another thing that I know on a very granular basis as a maternal and child health physician who's done capacity building in over programs in over 30 countries, it's just, I feel like we are ourselves messed up here in Washington, DC, in the US, and then we export those systems elsewhere with the power of our who we are as a country and how much money we pump into it. So sometimes it becomes counterproductive. So we have a big role to play to form relationships across the globe and here in US to make it make health equity actually less of a buzzword and more of a reality. And let's move to really quickly to who and what can we do to achieve health equity. And I think for a couple of minutes, because we are running short of time, I want my colleague, Sabina, to put a whiteboard so all of us can just write down what can be done to achieve health equity. Just very quickly, couple of minutes, and then Matt and I would reflect on what you guys have shared and add if we have things to add to that. Everybody can write on the same time, so please go ahead and write. What do you think can help achieve health equity? It could be a single word that you want to use. And you can also put in the chat. If that's easier for you, just put in the chat and one of us will put it on the board. It's like a 1.5 year, I feel like I don't know about others and Matthew, it's the interactive thing that I miss. If we were in a workshop, if you recall, we'll get everybody around the board and it becomes like an art piece at the end. People writing on it.
It's true. I missed the giant sticky notes on walls. I feel like this is a good quarter of my life is giant sticky notes on walls. Yes.
Yeah. And I miss that energy when, people were excited to walk up to the whiteboard, use the markers, different colors. It was a lot of fun.
Vineeta, it looks like maybe the document is actually locked and folks can only can only see it. So maybe we should just read some of the ones that are being thrown up.
Okay, very good. Or we can just get started. Let's just
Looks
get
like
started.
they're making everybody, now it looks like people have access. So this is good, but there are a bunch of great stuff in the chat.
Yeah, awesome. This is great. I see some involve people being affected in decision-making, rural areas, clinic in areas where low rate of health services, creating a sense of urgency, leveraging community health workers, train more nurses in low economic and marginalized communities, local communities. I think access, inclusiveness, great ideas, great ideas. Okay, great. Matt, do you want to get us kick-started on what's coming and what you think is the big buckets on that?
No, this is great. I mean, I see a couple of really important pieces. So one, it's really interesting to see the folks who are kind of thinking about the big structural questions, right? I mean, I see one that's redistribute wealth, right? Which is I think right, which is part of this, right? To me, one of the core questions is you can do global health in ways that does address inequity, or you can do global health in ways that actually increase inequity, right? And I think this is the core question. Maybe I'll close with a few of those things when we've got a moment, because I think that those are the things to wake up thinking every day is what are the pieces that we could be advocating that actually would have an impact on health. And we want to lift everyone's health. The point is not that we want the top to stop getting better. But to me, the core question is is that where our work needs to go? Or instead, does the work need to go into closing those gaps and will everything else follow, right? And so you can make different decisions. So things like measuring how funding is spent, I think is key to see, do we actually track where the funding is going? Is it getting to the communities that it's intended to go to? And think about that, right? I think that somebody says in here, better representation and leadership and governance across various dimensions. I think this matters a lot, right? Because when leadership and communities from low and middle income countries are at the table, low and middle income countries get better outcomes. But that is also true inside, right? Is it just the Minister of Finance who's at the table at the World Bank? Yes, right? Instead, do we need communities who are actually affected by the folks there to actually be at the table to make sure that what we're doing is not necessarily bridges, because that's not what we need? That also matters, right? And so in the design of strategies, thinking about within countries, those are key pieces, I think. What else do you see?
Thank you so much. And a lot of good ideas we can't really get through. It was a 45 minutes work session, and health equity is such a huge topic. We could spend years on it, let alone a day. So I want to end this session, but please follow us on Twitter. We are going to share your ideas that you have shared with us in the chat, and we'll keep the communication going and dialogue going throughout the day today and afterwards. We would like to end the session with some ideas that you can put to action to help achieve health equity from the action perspective, action partnership perspective, and results perspective. But before we do that, can we quickly have a picture? Remember the days when we used to have a picture, everybody huddle? So can we make ourselves, whosoever is comfortable on the video, switch on the video. Thank you so much for indulging. It's a virtual meetings. It feels good to have everybody together.
All right, so I will give a countdown. There are 3 screens that I'm going to have to go through. So if everyone could just keep a nice, lovely smile on your face for a good minute, I'll let you know. So counting down, ready. Hold on. Count of 3. 1, 2, 3. All right, that's screen 1. Thanks for your patience. Sorry.
The question is, which screen am I on?
I know,
We're on screen 1. Hold on, here we go. All right, ready. 1, 2, 3. One more screen. Count to 3. 1, 2, 3.
Awesome.
All right, thank you,
Thank
everybody.
you. Thank you, everybody, for your patience and joining. And it's just been amazing. And what you can do is few things. We'll put that in the session briefing also as well. And we invite you to engage with our vaccine equity campaign, tweet at your representatives and Biden administration. If you are from outside of the US, of course, you can tweet at your government officials, but you might consider tweeting at G20 and G7 about endorsing TRIPS waiver, which allows for more flexibility in intellectual property for COVID-19. Ask your leaders about sharing unneeded doses of the COVID vaccine to be shared. It's a burning issue. And at the end, I would like to thank my co-panelist, Matt Kavanagh, and all of you for such a great interactive session. Thank you, thank you, thank you.
Thanks, Vineeta, and thanks for pulling this together. Just quick closing thought to me. I think if we can be in a place where each and every piece of what we're advocating, we think to ourselves, is this the thing that will most close inequities? Or is this the thing that might advance everything well, but actually will do nothing to close inequities, right? And if we can ask that question for every single policy and every single program we're asking for, then I think we're gonna make some progress. So thanks very much, everybody, for being here.
Thank you.
Thank you. It's great.
Thank you.
Okay, awesome.
Great session.